What is colposcopy? It is a very important procedure to detect and for early manage of cervical cancer. An instrument called colposcope. It is a magnifying instrument to magnify the area examined cervix. Using this, examiner can easily detect the abnormal cells. Why do we perform colposcopy on patients? It is often performed when a pap test results is abnormal. It is to detect precancerous lesions, and other abnormal tissues. Let's go over what is HSIL and how it is detected and managed. HSIL or high-grade squamous intraepithelial lesion refers to certain abnormal changes in the cells on the surface of the cervix. If left untreated, these changes are more likely to progress to cervical cancer. HSIL is detected and diagnosed when a pap test indicates the presence of HSIL. Colposcopy is usually recommended. It helps highlight areas of abnormal cell growth that might require a biopsy. If abnormal areas are identified, biopsies are taken. These biopsies are then analyzed to confirm the diagnosis of HSIL and to assess the severity of the lesion. Colposcopy not only helps in diagnosing HSIL, but also in planning the appropriate treatment. Depending on the severity of the lesions, treatment may include procedures like excisional biopsy to remove the abnormal tissue. After treatment, colposcopy may be used in follow-up visits to ensure that the abnormal areas have been fully treated and to monitor for any recurrence of HSIL. Colposcopy is crucial for preventing progression to invasive cervical cancer. Early and accurate diagnosis allows for timely and effective treatment. Accurate detection and treatment of HSIL through colposcopy significantly improve patient outcomes by reducing the risk of cervical cancer development. Next is the characteristics of HSIL seen in pap smear. Firstly is high NC ratio, which also shows nucleus enlargement to 10 times. Next is hyperchromatic with coarse chromatin, followed by scanty cytoplasm. It also has thick, irregular nuclear membrane and groove is seen.
Today, I want to explain cervical cancer. Cervical cancer starts in the cells of the cervix, the lower part of the uterus. It is mainly caused by the human papillomavirus, HPV, a sexually transmitted infection. Cervical cancer usually develops slowly and often has no symptoms in the early stages. As it advances, symptoms may include vaginal bleeding, pelvic pain, or pain during sex. Regular screening is important because of this. HPV is usually cleared by the immune system, but in some cases, it can persist and lead to cancerous changes in cervical cells. For screening, there are two main tests, the pap test, which checks for abnormal cells on the cervix, and the HPV test, which detects the virus. To prevent cervical cancer, regular screening and the HPV vaccine are highly effective. Early detection is crucial for improving cervical cancer outcomes. 1. Increased survival rates. Detecting cancer early increases the chances of successful treatment and higher survival rates. Regular screening can catch precancerous changes early. 2. Effective screening methods. The pap test and HPV test are key for early detection, helping to prevent cervical cancer by finding abnormal cells before they turn cancerous. 3. Vaccination and prevention. HPV vaccination, recommended for girls aged 9 to 14, along with regular screenings, helps prevent cervical cancer. 4. Minimizing invasive treatments. Early detection often means less invasive treatments, reducing the impact on patients and the healthcare system. In summary, early detection and prevention are vital in combating cervical cancer. Cervical cancer is a major issue in Malaysia, being the fourth most common cancer among women. In 2020, there were around 1,740 new cases, and 991 women died from it. This high death rate highlights the need for better screening and prevention. The risk is especially high for women aged 15 and older, with about 12 million at risk. This underscores the need for HPV vaccination and regular screenings. Cervical cancer is the second most common cancer among Malaysian women aged 15 to 44, showing that younger women are also highly vulnerable. In summary, improving screening, vaccination, and awareness can significantly reduce the impact of cervical cancer.
There are two non-significant factors. Meaning of non-significant factor is the factor that does not provide sufficient evidence to conclude that there is an effect of HSIL detection. The first one is HPV subtype. This factor is non-significant because colposcopy and biopsy process focus on visual and histological examination rather than the virological profile. According to this journal, there are highest number of HPV 16 active cases. This HPV is high-risk HPV, which is can lead to HSIL. The other type is low-risk HPV, which is benign infection. The second non-significant factor is age. The accuracy for HSIL detection decreases with increasing age, so among older women and HSIL cases were more likely to be missed. It is also because of changes in the cervical transformation zone, making the cervix less susceptible to new infection, so it is more difficult to detect with colposcopy. According to Stoops et al., it is also might be related to menopause and to unidentifiable cervical lesions with limits that are not easily visualized using colposcopy.
There are three significant factors influencing the accuracy of colposcopy biopsy in detecting high-grade squamous intraepithelial lesion (HSIL). One of these factors is the number of biopsies taken. The accuracy of detection improves with an increasing number of biopsies. Specifically, taking 2 or more biopsies has been shown to significantly increase the sensitivity of detection. Gage et al. Found that the sensitivity of the colposcopic procedure did not vary significantly according to the professional characteristics of the colposcopist. However, the sensitivity was notably greater when colposcopists performed 2 or more biopsies. Wensenson et al. Reported that the highest sensitivity for detecting high-grade dysplasia was 95.6% after taking 3 biopsies, in accordance with the standards set by the American Society for Colposcopy and Cervical Pathology, ASCCP. Another crucial factor is the cytology results. The sensitivity of detecting high-grade lesions varies with different cytology results as stated in the given picture. Patients with low-grade squamous intraepithelial lesion, atypical squamous cells of undetermined significance and atypical squamous cells, cannot exclude high-grade squamous intraepithelial lesion results had lower odds of accurate detection compared to those with negative for intraepithelial lesion or malignancy results. Colposcopic impressions are more likely to overestimate rather than underestimate the severity of lesions. The highest number of false negative cases typically occurs within these classifications. Therefore, clinicians may need additional indicators to determine whether a second or even third biopsy is necessary. The last significant factor influencing accuracy is the transformation zone. Studies have shown that diagnostic accuracy is highest in Transformation Zone 1, TZ1, and lower in Transformation Zone 3, TZ3, with stated results as follows in the picture given. Transformation Zone 1 represents the area where the entire transformation zone is visible, whereas in Transformation Zone 3, the upper limit of the transformation zone may not be fully visible, potentially leading to misleading results. In this study, diagnosing high-grade squamous intraepithelial lesion using the method colposcopy is 69.7% accurate compared to doing cervical biopsy analysis. The colposcopic impressions are often biased by medical history of patients and previous tests such as Pap smear results or HPV results. This is because the results are used as a guidance by clinicians to guide their approach during the colposcopy. As shown earlier in the video, colposcopy is considered a subjective procedure, as it is dependent on the clinician's assessment. Then the clinician will determine the needs to do any biopsy or which specific site is needed for the biopsy. According to the analysis in this study, the number of cervical biopsy sites appeared to be significant to colposcopic accuracy. An increasing number of biopsy sites with colposcopy accounts for 1.15 times higher accurate detection. In another study, Gage et al. Found that sensitivity was significantly greater when colposcopists took 2 or more biopsies. However, the optimal number of biopsy is depending on patients' prior risk. Not all cases are suitable to do multiple biopsies. For example, in this study, it was found that patients with cytology results below an ILM, or negative for HPV types, or positive for HPV other than HPV 16 and HPV 18 would have limited benefit from the additional biopsies. This is caused by the risk of overdiagnosis of detecting high-grade squamous intraepithelial lesion cases using colposcopy. Overdiagnosis in this study is considered present when the histopathologic biopsy results are found less advanced lesions than colposcopic examinations. Therefore, it is important to carefully evaluate the findings from the colposcopy to determine the most appropriate action for patient's treatment. Last but not least, we will discuss about sensitivity and specificity of colposcopy and biopsy for HSIL detection. The colposcopy accuracy is 69.7%, meanwhile sensitivity for this method is 42.35%, and the specificity for this method is 77.6%. The PPV value is 33.53%. It is low. It indicates there is higher chance of false positive in diagnosing HSIL using colposcopy and biopsy. The NPV value is 64.47%. The level of NPV is low. It means there is higher chance of false negative. There is possibility where patient with HSIL but unable to detect using colposcopy and biopsy. These are three factors that influence the sensitivity and specificity of colposcopy and biopsy in HSIL detection. They are age, number of biopsies taken, and type of transformation zone in women. The first factor is age. The sensitivity for HSIL detection decreased with increasing age, and HSIL cases were more likely to be missed among older women. Occurred because of age-related biological changes in the cervical T-zone, or perhaps making small lesions more difficult to detect with a colposcope. Kim et al. Reported that the balanced accuracy of colposcopy-directed biopsy was 81% for those below than 35 years, 74.4% for 35 to 50 years, and 68.8% for those older than 50 years. Second factor that influenced the sensitivity and specificity of colposcopy and biopsy in HSIL detection is number of biopsies. The sensitivity of enrollment colposcopic procedure did not vary significantly according to colposcopists' professional characteristics, but that sensitivity was significantly greater when colposcopists took 2 or more biopsies. This finding has been confirmed by a study by Robert and Wensenson, who reported the highest sensitivity for detecting high-grade dysplasia was 95.6% after taking 3 biopsies, according to the standards of the American Society for Colposcopy and Cervical Pathology, ASCCP. Therefore, second-look biopsies and perhaps even a third biopsy may be necessary to ensure we do not miss opportunities to intervene, and future study using larger sample sizes might be conducted to improve the performance of colposcopy based on stratified patient risks. Lastly, type of transformation zone. The components of TZ1 mean that the entire transformation zone is visible, whereas in TZ3 the entire upper limit may not be visible and therefore can be misdiagnosed. Regarding the Table 5, the rate of overdiagnosis was worse in women with TZ3, 19.74%, whereas women with TZ1 or TZ2 appear to be overdiagnosed with 12.91% and 14.73%, respectively. Table 5.